So welcome to tonight's COVID-19 question time webinar. I was trying to remember when the last one was, and I think we were still in the Euros, weren't we? And it was quite a hot summer evening, and the webinar managed to be in the middle of England playing maybe the semi-finals or the quarterfinals, I can't remember. Anyway, but we managed to finish in time to see them win that match. and hopefully people who are here from the other devolved nations won't be too offended by my memory of that particular evening. Anyway, things have changed a bit and we've moved on since then. So thank you to all of you who have sent us in your questions. Hopefully together we will be able to have an informative and great discussion this evening following the things you've been asking about and following some of the later developments in things to do with COVID-19, whether that's vaccination, going back to work, antibodies, or emotional well-being. Those are some of the things that you've asked us about tonight. So what we're going to do is, and I can see there's already a question in the question box. I'll go through some of the ways in which this is working. And then I'll introduce you to our fantastic panel of speakers and contributors tonight. I think that's all I wanted to say just at the moment. If we could move on to the next slide, please, Kelly, that would be great. So just some things about how we're going to be working tonight. So if any of you happen to want to use social media, that's COVID question time, and we're at Kidney Care UK. I can see that Joe, somebody has already posted a question down in the Q&A button, so has evidently been here before. And so do feel free to post your questions as we go through at the bottom of the screen there in the Q&A box. And you can upvote any of the questions if you think, oh, that's a good question, I'd like to hear an answer to that. You can do that. For the chat box, that's really for technical questions. I can't hear you, can you help me, whatever, that would be good. I'll introduce you to our various technical team there as well. So, but if you could put your questions in the Q&A, not the chat, please. So that would, just so we can keep them separate. So if you put, I think someone just put one in the chat, if you don't mind putting in the Q&A, that would be easier for us. Super. So the webinar is being recorded and it will be made available on YouTube afterwards with some subtitles, and a further summary report we'll be publishing, and everyone who attends will be sent a link to that. So I think it's time to introduce our panel members. If we could go on to the next slide, please, Kelly. I can see everybody's name, and if I could ask my fellow panel members to switch their cameras on as well. Right, start to see everybody's faces. Thank you so much. Right, so who have we got with us tonight? So we've got Dr. Andrew Frankel, kidney doctor at Imperial. So thank you, Andrew, very much for joining us yet again.
Good evening.
Partly your fault for suggesting it recently, but actually we knew it was time to do one of these anyway, because people have been asking a lot of questions. So thank you very much indeed. Then we've got, oh, there you are. We've got Professor Richard Haynes, who's Professor of Renal Medicine. He's based in Oxford, and he's got some of the knowledge of some of a whole range of clinical trials. So welcome, Richard, and thank you for managing to join. I know that both you and Andrew had other commitments until about 10 minutes ago, so I'm very grateful for your time. So thanks. Then we've got Dr. Rebecca Suckling, and that's Becky there. Some of you, so she's a kidney doctor at Epsom and Helier Hospital, and she has been, again, a real stalwart for us of these webinars, answering your questions in the Q&A, and I can see that already starting to go up, answering your questions in the Q&A, you know, as we go through. Now, some of the questions we'll be able to answer, and you'll also hear them answered in what we've got to say, and some of them, because those questions have been asked in advance, and some we'll pull up for answer. We'll pull up for answer verbally, and some will answer as we go along as well. So we do a mixture of all of those things. So that's Becky, and I'm sure we'll be bringing her in to speak from time to time as well. So and she's prepared for that sort of. And then we've also got Dr. Michelle Willicombe. So thank you, Michelle. Also kidney doctor, also based at Imperial, but also a researcher and a lead in some of the important trials like Octave and some of the others that we're referring a little bit to later on. So thank you, Michelle, for joining us this evening. And if I can see Sarah, there's Sarah. There she is. Hello, Sarah. Right. So tonight, what we've also done is one of our counsellors, our fantastic team of counsellors, and this is Sarah Vickery, who's joining us tonight. So at the end, or towards the end of the session, we'll be talking a little bit about emotional well-being as well, because it's been difficult, hasn't it? So we can talk about some of the medical answers to some of these questions as well, but maybe some thoughts about dealing with it and how we live with this. So that'll be a sort of shorter conversation with Sarah and I towards the end. And thank you very much, Sarah, for agreeing to join us this evening. So also not on the screen, but you will see that they're there in the background. We've got 3 of our fantastic Kidney Care UK team. So Kelly, who is tonight, she's providing all the technical support. She's got a million different roles in Kidney Care UK, but how she's helping us tonight. So it's great. And we've got Sharon on here, who's our comms and media manager, and we've also got Sam Sharp, who's our senior policy officer, who works for me in the policy team. So, and we've got our WhatsApp going on to address some of the questions and things as well as we go along. So what I'd like to do, if I may, and Kelly, this is sort of to you as well, is if we could switch the slides off just for a moment, and just perhaps ask Andrew, everyone else to switch their cameras off for now, and just ask Andrew and myself just to go in for a kind of an introductory session where we've asked Andrew just to give a sort of broad overview of the current situation, and just, where are we at the moment? And it might be worth us kind of rehearsing some of the things about, just to remind everybody that we have actually moved on quite a long way. So Andrew, if we could highlight you just to do the
yes, I suppose the pandemic in 30 seconds.
Longer,
not easy,
a bit longer than that.
but we have, of course. This is, I think, the third or fourth one of these that I've done, and I introduced the previous ones with yourself, and I think we're now into the third or fourth wave. I think there's some very key points to make. There is no doubt that we have gone a huge distance since March 2020. There is also no doubt that the pandemic is continuing, and the number of people in the country picking up COVID-19 remains actually very high. So the virus has definitely not gone away. But there are some very important differences from when I was here talking with you, Fiona, in early 2020, and indeed in the summer and the winter of that year, because while infections are frequent, hospitalizations and death rate, thankfully, is significantly less compared to the infection rate than it was in the first and second wave. And that's related to a number of factors, and that includes the vaccination program, with most people being double vaccinated and indeed now being triple vaccinated, and also considerable advances in how cases of COVID-19 are managed. And I'm hoping that during this webinar that you as a participant, all the participants, will get to hear, particularly from Richard and Michelle, to go into more detail of some of these enormous advances. And I think we really do need to pay tribute to the scientists involved, because within 18 months of the pandemic, the pharmaceutical company, the UK scientists, all the organizations have actually got us to the point where we have successful vaccines and we have successful treatments. And that is extraordinary, considering this virus has only been known for a period of 20 months. So why are we actually here? Well, we're here because as a community of people with kidney disease, you all still remain at some degree of risk from COVID-19. And you all still have questions about what that risk is and what can be done and what you should do and what the system should do and what your unit should do to help reduce the risk for you to get infected, and if you did become infected, to suffer from a poor outcome or an adverse outcome. And I think that's what we will be trying to concentrate on in this webinar, bringing you all the news of all the good things, but also highlighting where we still need to be cautious. Fiona.
Thank you, Andrew. And can I just ask a really sort of straightforward belt and braces question that I know we didn't talk about it beforehand, but you'll be fine with it, I promise you, which is just somebody said, because the rates, as you say, hospitalization and so forth is lower, but the rates of COVID, let's face it, they aren't as low as I'm sure we'd all like to be. But just to remind people that if they suspect they have, well, first of all, to do regular lateral flow testing, but what they should do if they do get a positive PCR test, and what they should do, what they should tell their kidney unit and so forth. So but just belt and braces, if you could just run through
so
that
there's a bit that they should do as an individual, which is once, of course, you've had a PCR, you are going to be tracked and traced, and you need to self-isolate. You need to ensure that the people within your household are aware so that they can take appropriate action. So there's all of that piece of activity that anyone who has COVID-19, whether you're a kidney patient or anyone, should be able to do. What is also really important is if you become positive, or if you develop symptoms that might be COVID, you should ensure that your kidney unit are aware of your situation. Particularly, well, actually, it's the same if you're a dialysis or a transplant patient. I think there's an urgency for dialysis because you may very well be going up to the hospital 3 times a week, and the unit needs to make plans for how they can both look after you, but also ensure that you're not going to infect someone else. And for transplant patients, to ensure that you are aware and you are monitored for any consequences of that infection. So there's the pathway which you need to follow as anyone would with COVID, but there is that extra step that you have to do as a renal patient, as a kidney patient, which is inform your unit so they are aware, and they may wish to keep in contact with you, even if you're a transplant patient without an appointment, to see how you are doing.
Thank you. And I think it's just a really important reminder because we've all been doing this for a long time, but there is a bit of a rotten cold around at the moment as well, and it's still important to make sure you get yourself tested, as it always has been. So just one of those things, isn't it? But I think I just wanted to restate that some of the basics there for people. So thank you, Andrew. I told you that was a difficult question at this stage anyway. So great. Okay, thank you. And thank you, Andrew, for your wisdom there as well. And shielding has paused. Things have been opening up to a certain extent. So that's why I think it's important for us to start to focus on what we can do, how we live with this, and what can help us do that. And I am living quite dangerously tonight because I've got the dog in the room with me, but he's just leaving, I'm happy to say. Right, okay then.
Well, I have a cat on my lap, so I'm
not quite as noisy as a dog potentially is. So great. Okay, thank you. So Richard, if I could ask you to come on to the camera, please. And there you are. Hi. And what we're going to do is we're going to Kelly, could you just put on the next that single slide, please, as well, just so people will know what this section of the webinar is going to be covering. Okay, so we've rounded up your questions into various chunks. So we'll be talking, and we've just talked a bit definitely about the sort of current risk from COVID, but we've got some very specific questions about kidney patients and so forth. And then we're going to be looking at some of the latest vaccine research, things about third dose and antibody tests as well. So those will be the areas where we're going to be covering in this section. And I can see there's an awful lot of questions popping up down below there. So let's see where we go with answering your questions live too. Right, thank you, Kelly. Let's go back to Richard and I, if that's all right. So, Richard, a sort of general question, I suppose, to open this up, and I know Michelle will be joining us for this section as well shortly. So, just some of your thoughts about what the data is showing us at the moment about how COVID is affecting kidney patients relative to the general population, and any kind of particular things you might be able to speak to about numbers of people getting sick, going to hospital, and so forth.
Okay, thanks, Fiona. So I think I'd echo everything that Andrew just said. I think what we know is that people with kidney disease are at slightly increased risk of catching COVID, and if they get it, getting more unwell with it than people without kidney disease. But it's not an all or nothing sort of feature of having kidney disease. It's a gradation. So the worse your kidney function, probably the higher your risk. We know that people on dialysis, and particularly people who've been transplanted, are at higher risk than people without. But I think there are many other things around which affect people's risk as well. And kidney disease is only one of a whole number of different things. And I think what remains by far the strongest factor for getting poorly with COVID is your age. We know that the risks from COVID are strongly related to age. And in fact, sometimes what a useful thing to do can be is to compare different risks with each other. We know, for example, that people from ethnic minorities are at increased risk than people from the white community. Actually, the difference is only equivalent to about 6 years in age. So somebody who is a white person 6 years older than somebody from an ethnic minority is about the same risk. So you can sometimes you can compare risks a bit like that. And having kidney disease is probably similar. Having kidney disease might be equivalent to being 6 to 10 or maybe 15 years older than somebody else in the general population. So it doesn't mean that people with kidney disease have a terrible time with COVID, but they have on average, they tend to have a harder time than people of their same age, but maybe equivalent to somebody who's 10, 15 years older than them.
What do we know about sort of, have we got any feeling for the kind of the numbers of people who are having to go into hospital to be treated as opposed to being able to manage at home?
Yeah, so some of these numbers we see on the news every night. If you can face the news, sometimes I can't. But I think at the moment the numbers going to hospital are fairly static. There's about 1,000, maybe just under that, people going into hospital every day at the moment, which is much lower than it was, say, in the winter, January, February, earlier this year, when the numbers of people going into hospital every day was several thousands. So the numbers of people going into hospital every day is much lower. And the number of people dying every day from COVID is lower than it was before. It's not zero, sadly, but it's much lower than it was at the start of this year. And I think what we know is that of the people who do go into hospital, the outcomes are better than they were. Andrew's already touched on this. It's partly because of vaccinations. It's partly because of the treatments we can offer. It's also partly probably things that we can't measure very well, that hospitals just know what they're doing more with people with COVID, whereas last year it was some hospitals, we were all learning, sadly, about this new disease, and we have learned quite a lot. So I think things are all going in favourable directions, but as Andrew said, the virus is still around, and sadly some people are still dying, but and going into hospital, but I think at lower rates than they were before. So things are definitely going in the right direction.
Okay, thank you. So how does kidney stage affect outcomes from COVID? And then I suppose there's a sub question in there. What about if you've only got one kidney? And I don't mean kidney donors. I mean people who only have one kidney because that's how they were born.
Yeah. So kidney stage as I said a minute ago, the worse your kidney function, the higher your risk of getting poorly with COVID and maybe needing to go into hospital. But it's not a huge effect. It might be if you had, say, stage 3 kidney disease compared to somebody with normal kidney function, maybe your risk is equivalent to being about 5 years older. If you had stage 5 kidney disease, in other words, you're about to start dialysis or need a transplant, compared to somebody with normal kidney function, maybe it's the equivalent to being 10 or 15 years older. But it's not a really strong effect, but there is some effect. In terms of people who are only born with only one kidney, usually those people have pretty good kidney function, and it's probably the level of kidney function that count. So I would say they're probably not at much higher risk than somebody who was born with 2 kidneys. I'd say the exception to that is some of the medications that we sometimes give people with kidney disease. So some people with kidney disease, nearly everybody with a transplant, and some people with other forms of kidney disease need immunosuppression, where we try and dampen down their immune system. And that being on those drugs does seem to be another risk factor, in addition to whatever your kidney function is bringing to you. Being on those sorts of drugs does increase your risk further. And I expect Michelle will have something interesting to say about the effects of those drugs on how, for example, how you respond to your vaccine.
Yeah, no, definitely. And that is one of the key questions that we've been asked, and we will be discussing anon. So yeah, so I think the age thing is a really helpful way for people to think about it as well. I think so. That seems to be something that seems easy to understand and relate to there. Is there anything at this point you wanted that you felt was worth mentioning about any COVID treatments? I know we've got more detail to talk about later. So is there anything you wanted to mention here?
I'll probably leave the detail till later, but I will. I mean, it is, as Andrew said, it is quite remarkable that we now have a number of different treatments which can be given to people with COVID, which we know have improved outcomes substantially. And so that really is an encouragement to everybody, because we're all at risk from COVID. And so knowing that there's treatments out there is really helpful. And we're hearing more and more every day.
We are, and we'll be talking about that in a bit.
Yeah, so I think the short summary is that undoubtedly there is a treatment there which will work for pretty much everybody. So hopefully we can, it's just a matter of getting them to the right people at the right time, and that's what the NHS is working at for some of them at the moment. And that's certainly what we at Kidney Care UK, those are the kind of questions that we're of course asking, is how do we get to these things? And I know some of those are new. Anyway, that's for later on. Okay, thank you, Richard. There's another question here actually, which is about how having COVID affects your kidney function. And I know that some people, as said, some people will get COVID, they might be a bit poorly for a short while. This has been just the experience of people that I know, and they'll be okay, they'll be absolutely fine again after they've recovered from being exhausted and not feeling very well for a bit. And there'll be others who will have, it'll affect differently. And I don't know whether there's anything that you're able to say about the impact of having COVID on kidney function. Yeah, so I think the first thing to say is that the vast majority of people who get COVID, like you described there, Fiona, they feel lousy at home for a week or two, and then they get better. And as far as I'm aware, there's no information to say that sort of COVID has any detrimental effects on your kidney function. Obviously, some people end up in hospital, and the people who end up in hospital are generally sicker, and some of them do develop worsening kidney function. That can happen to people who don't have kidney disease to start with. Yeah. But we know that if you've got kidney disease in the background, then if you get another illness bad enough to take you into hospital, your kidneys are a bit more vulnerable, and the function will probably is more likely to get worse while you're in hospital. That's nearly always reversible, so that when you get better, your kidney function will hopefully return close to your baseline, or pretty close to what your baseline was before. Mm-hmm. That said, a small minority of people, the kidney function when they're in hospital will be bad enough that they might need a period of dialysis or some treatment like dialysis to tide them over. And I think whether your kidneys recover from that really depends on how close you were to dialysis in the first place. If you were somebody who was going to be starting dialysis in the next 2 or 3 months, then COVID, if you like, and you end up in hospital with COVID, that will bring it on. Yeah. Forgive the analogy, that might be the straw that breaks the camel's back, and that means you need to start dialysis that bit earlier. But if your kidney function's pretty good, you're less likely to need dialysis, and even if you do, you're more likely to get off it again and hopefully get most of your kidney function back. But I don't think we know a huge amount about this yet. There aren't any not many studies on it. There are a few studies, but nothing that we can say definitively. And so unfortunately, the variation between people is so big in this regard that it's quite difficult to know for an individual what that would mean. But I'll just say again what I started with: the vast majority of people with COVID don't end up in hospital. and as far as we can tell, it has no detrimental effect on kidney function in that situation.
Okay, thank you very much, Richard. Thank you. I wonder if we could now ask Michelle to come on to the screen and get highlighted. I can't see you. There you are. Great. It was good if I can see you. Thank you, Michelle. So I know others have sort of queued you up already for some of these questions, but we're going to talk about the third primary vaccine dose in a minute. And I think most our audience would not be surprised about that. But just one thing for you, if I may, which is a question that we thought you might be able to help with, about any specific treatments affecting outcomes of COVID, and whether there are, and we had a couple of questions about people on, prednisolone or MMF, and whether any of those treatments had a particular effect on how well you do if you get COVID.
Yeah, so early sort of pre-vaccine, certainly any patient who was on immunosuppression, fortunately, because their immune system was weakened, were more likely to have a severe form of the infection. But there is great variability in the types of immunosuppression that are used. And certainly it seems that the more immunosuppressed you are, so the different how far out from treatment you are and what combination of therapy you are might predict that risk. But certainly compared with people not on immunosuppression, as Richard highlighted, the immunosuppressed patients overall have a worse prognosis in terms of infection risk. Unfortunately, it's the same people with a weakened immune system then also have a sort of a worse response to the vaccines, and this is because they're on medication which is working to treat their underlying condition, keep them healthy because they've got a transplant, etc. But unfortunately, a side effect of that is that they can't mount the same immune response to infection when it occurs.
Thank you. And I know some people do mount a response and some people, so it does again vary by individual.
Absolutely, yeah.
Right, okay. So let's just kind of acknowledge some things about the third primary dose, which is that the rollout hasn't been as good as we would have liked it to be. And also just to kind of remind people that the third primary dose of the COVID-19 vaccine can be given anytime 8 weeks after your second dose, and it's called a third primary dose because that is targeted at the people you've just mentioned who have a suppressed immune system, for whom it's considered they may not have made as full a response as anybody else, should we say. So that's the third primary dose, and that is different from a booster dose, which is given 6 months after someone's had their second dose, and is advised because their immune response may be waning over time. Yeah,
that's absolutely right. I sort of name it as the third primary dose is a catch-up dose for those with weakened immune system to catch up with everybody else, and the booster dose is a wake-up sort of dose. And just to say, those patients who had a third primary dose will get another vaccine at 6 months, will get a booster dose 6 months after their third primary.
Lovely. Okay, that's great. I thought it'd be important to remind everybody of that. And the other small thing to remind people, which is that if it's a third primary dose, well, in fact, whichever it is, you're going to get a Pfizer or a Moderna vaccine. But if it's your third primary dose, you should have be given a full dose of Moderna. But if it's your booster dose, you would be given a half dose of Moderna. The chances are you wouldn't know that anyway, probably from the vaccinators themselves. But it's just from the patient's point of view, I think it's probably a good question to ask. Would you agree?
Absolutely, yeah.
Okay, so just to be clear, if it's a third primary dose or a booster dose, it's Pfizer. But if it's a third primary dose, and you get offered Moderna, it's a full dose of Moderna. But if it's a booster, you'll be offered a half dose of Moderna.
Yes.
Right.
Yeah.
Okay. And everyone I've talked to who's had any Pfizer, either through booster or otherwise, has actually shown less reaction than they did to the second and first doses, curiously, which is possibly just anecdotal, but I thought that people might be interested in hearing that if you're worrying about the side effects and things. I don't know if you'd heard that at all, Michelle.
Again, it's variable, but remember, some of the patients would have got to to AstraZeneca for the first 2 doses. So they're experiencing the mRNA for the first time. So they may experience some different symptoms, but it's variable, hugely variable.
Great. Okay, thank you. Okay, so I wonder, Michelle, if we could ask you now to sort of speak to kind of some of the key stats from vaccine research, what research is going on at the moment, when some of the findings will be available, and then what that might mean to people. I know that, you've been leading on the Octave and the Octave Duo, and about the PROTECT study and some other things. So perhaps if you could just give us a bit of a roundup of those, please.
Yeah, of course. So there's lots of data out there in terms of immune responses to 2 doses of vaccine in patients with kidney disease and on immunosuppression. There's probably less data still on the real world efficacy of these vaccines in the same population, which is reliant upon registry reporting. But what we found, or what generally has been found, and again, there's huge variability across different cohorts and even within the same cohorts. The dialysis patients actually have been responding very well to especially the mRNA vaccine, and that's Pfizer mostly. A few people have had Moderna, but over 90% of dialysis patients may mount a response to COVID vaccine. Patients who are immunosuppressed have less responses. So we've reported, which is the largest series in the UK, in collaboration with Octave on transplant patients, and just over half of transplant patients had a antibody response following 2 vaccines. The Octave study reported responses for patients who had glomerulonephritis, who had autoimmune disease on immunosuppression, and up to 60% of those had antibody responses. But again, it varied depending upon the treatment. For those who are receiving active treatment, especially with a drug called rituximab, which its main aim is to stop antibodies in their track, only about 25%, so 1 in 4 of those patients had antibodies. So in summary, in dialysis and CKD, the antibody responses were actually better than we were expecting, because most other vaccines in this population don't perform as well in terms of the immune responses, whereas those on immunosuppression unsurprisingly had weaker responses. But we sort of moved on from the 2 doses, because obviously when we saw that the patients were having weakened responses, the aim was to get the 3rd dose, them access to the 3rd dose. So there's the current study looking at 3rd doses is Octave Duo. And this is important because it's a randomized control study, which is taking 1,200 patients with weakened immune systems.
So I'm going to stop you. I'm going to stop you there and say, can you explain what a randomized controlled study?
Oh yeah. So patients. So patients are selected at random to receive 1 or 2 vaccines. So the inclusion criteria for the trial is that everybody had to have either no antibody or a low antibody response to 2 vaccines. And when they enroll into Octave Duo, at random, selected at random, they'll either receive a 3rd dose of Moderna or Pfizer vaccine. Right. And that will be interesting because Moderna is stronger, has more mRNA in it than the Pfizer dosing. So actually, it'd be interesting to see whether or not the additional strength of Moderna elicits greater responses in the people with weakened immune system. And that's due to report. The interim analysis will be a matter of weeks away for reporting for that.
Well, that sounds really interesting. Can I just also ask another question, please? You talked about these studies, but you also mentioned real world efficacy. Could you just kind of explain what that means as well?
Yes. So it's nice to be able to, we like tests and renal, we're reliant on tests, but actually the tests don't mean everything. And just because people say we can't detect one aspect of the immune response doesn't mean to say there's no protection. So the data that has come out of the, so certainly from, say, the NHS Blood and Transplant Registry, the data suggests that the vaccine, even after 2 doses, there is some effect, not as good as the general population, but some encouraging efficacy within actually the number of patients getting sick and unwell with infection. And the other real world data that was quite big was released in September, which was from the Office of National Statistics, which basically looked at people who had breakthrough infections. So a breakthrough infection is patients who get COVID infection despite being fully vaccinated. So that was with the 2 doses of vaccine. And that data suggests that, as Richard highlighted, it's the age group, it's the older patients, but also patients that are on immunosuppression. They were also at slightly higher risk of getting breakthrough infections. But it's that real world, it's what we're seeing rather than what we're measuring in the lab.
Right, okay, thank you. And also, are there any differences that we've seen by say the part of the country or by ethnicity or something from what we've seen so far?
From the vaccine efficacy?
Yes, from how well the vaccines work in
Yeah,
people.
not that I am aware of, and I don't know if any of the other panelists have seen any other data. What is I think what data has come through is that there is a difference in ethnicity in regards to vaccine hesitancy, but I'm not aware in terms of vaccine efficacy there being a significant difference. Okay,
so they work just as well or not as well depending on the treatment. So it's all to do with the treatment you're on and nothing to do with anything else. Right. Okay. Yeah. Well, that's a helpful thing to know. Thank you. Right. Okay. So let's move on then. So how necessary is the 3rd dose?
Oh, it's really definitely.
Should I bother getting it after all that?
Yes, definitely need 3rd dose. Give your, and even if you think you may not respond because you're heavily immunosuppressed or you've just had rituximab therapy, get the 3rd dose, and then you'll be due your booster in 6 months. And as data is coming through, there may be different advice as we go along, but certainly the real world data is suggesting that the vaccines are having some effect, or are effective, not even some effect, are effective in this group.
Which is the next question, because people are saying, how effective is the 3rd dose in terms of antibodies and protection from COVID?
Yeah, so we haven't, in terms of this population, I think because other countries are further ahead in terms of 3rd dosing, data will be emerging from Israel and the States and other countries prior to the UK. The real world data is lacking, but the antibody data there's quite a lot of from these countries who mostly have used 3 doses of the mRNA vaccines. And certainly what the data that's out there suggests that anybody who's had a response to the first 2 vaccines will get a boost in their antibody levels. And for the patients who unfortunately don't respond to 2 vaccines, up to half of those will develop a response after the 3rd. So get the 3rd. We don't quite know yet in terms of which of those patients will or won't develop a response after the 3rd vaccine, but that's good news that half will do.
Okay, indeed. And so we've just got a few questions here about the timing of the 3rd dose, because for some people, although we talk about this 8 weeks for the 3rd dose and 6 months for the primary, for the booster dose, for a lot of people who were vaccinated in January, March this year, they're also anyway at the 6 months, as it happens at the 6 month thing. So the question is from somebody was, if I've had a 3rd jab 7 months after my 1st, am I in effect starting again with an immune response? Is it a new start because I've lost it all and I've got to start all over again?
No, it's just that 3rd dose will give your memory a bit of a nudge. So there'll be an immune response. You won't be starting from scratch. If you had a response to the first 2 vaccines, when you come to have the 3rd vaccine, it won't be like starting from scratch. It will just add on to the responses and improve the memory responses of all the vaccines that you had previously.
Right. Okay. Thank you. And then so, and if you're on, well, I think we've kind of talked about this already, but on high levels of medication, I think we've already discussed that if you're on a higher level of medication, sorry, immunosuppressive medication, that may affect your responsiveness. But in terms of people, would that be personalised advice to an individual about how they should deal with that, and whether there should be any tapering off or anything like that of their doses?
I don't think, in terms of for vaccination, I personally feel that there shouldn't be any, certainly for transplant patients, any changes in medication made just to facilitate a vaccine response. There is a study going on in Europe looking at this in people who are on mycophenolate mofetil and stopping that. But what you don't want is to develop, say, a rejection episode, because that would then mean that you need even more immunosuppression. So you can certainly have a discussion, because it would be personalised, but there are some, I don't think there's enough evidence out there, certainly for transplant recipients, to think about stopping a medication to facilitate vaccine responses.
Very wise advice. And I think the UK Kidney Association absolutely advises that people don't do anything like that, but I think it's just worth repeating that for everybody, for everyone's benefit. And the other question we've got here is, if you've had COVID already, do you need a third jab because you've already got some level of immunity?
Yes, I would. So those patients who've had previous COVID, they do tend to have, they've got one of their memory responses from the infection. So they have higher antibody levels than patients who don't have any previous infection. But I would still go with the booster plan program as suggested. I wouldn't be guided just because you've had previous COVID that you don't need to now have a vaccination on top. Vaccine responses elicit very strong immune responses for future reinfection, which is possible, although thankfully not that common at the moment.
Okay, thank you. And then we've got a few questions really about levels of protection. I know you've addressed some of that after the third dose, and you've explained about how some of the studies, and what we see about that. But the kind of questions we're getting about, and we're going to talk about more about antibody tests anyway, but if you now have you've been told through a study that you've got a high level of antibodies after your third dose, can you assume that this offers you some level of protection?
I think it's probably safe to say the other way round. So we don't know, we don't know the correlation between what antibody level gives you optimal protection. And I said there's lots of different types of tests that you can have, which might provide different levels of information. But I think it's probably reasonable to say now, if you don't have any antibody response, you're probably not protected still. But I wouldn't say that patients, if someone tells me a level, and even it's a high level, you never know what's going to happen in terms of variants, etc., etc. And I still think certainly people that are on immunosuppression, should remain cautious at all times, while this disease, which is a new disease, is still evolving.
Right. Okay. Because we've been sent, people have sent us their numbers, and so is this a good level? Is not that a good level? And so those are some of the questions. But I think one of the kind of biggest questions there about is, and it's a really difficult one, because it may not just be a medical answer. It's about what level would be safe enough for me to feel like I could stop shielding. I think
that is, the shielding is a sort of a personalized choice. I think that, if you are sensible, if you're taking precautions, those around you are vaccinated. I don't think people should continue shielding now. As I said, there are treatments, and there may be different prophylactic agents that are coming out, and Richard will talk about them, no doubt.
Just explain what prophylactic means.
As in medicine that will help prevent either infection, or if in the first place. And these may, there's been so many changes made in the last, last 18 months that changes will continue. I think there has to, for mental health and well-being, I think there has to be some easing of strict restrictions. If you had your 3 vaccines and you're not, you're still being cautious, I think that, don't lock yourself away.
Right. Yeah. Okay. Because we've got to live as well. Yeah.
Yeah.
Okay. Okay. So a couple of very specific questions then. So can a person who's had 3 vaccinations carry the disease and pass it on to others?
They can, but what we do know is that vaccination reduces transmission. So it's less likely, and if those around you in your household have all been fully vaccinated too, that's going to be protective.
Okay, thank you. And if someone had just had a transplant really recently, and they've been double vaccinated and then they had a transplant, when should they get their third dose? Because I know there is guidance that says if you are about to have a transplant, you can be brought forward for your but on the other hand, sometimes that doesn't always happen. Someone gets called in the middle of the night and they haven't quite got to their next dose yet. So what would be your advice about when the timing of that should be?
So that's interesting. I think ideally people should have their 2 doses of vaccine pre-transplant, because if you've been vaccinated before your transplant, before your immunosuppression, actually it will protect you in the post-transplant setting, because your immune memory will be better than if you have it all post-transplant. The timing of that 3rd primary dose then after you're transplanted, we tend to give sort of flu vaccines anywhere between 6 and 12 months. I am not aware of precise timing, and it may be an individual thing in terms of your team advising when it's best for you to have that 3rd dose.
Okay, all right, it's an interesting question, that one. So thank you. Right, so time is moving on, but we do have to talk about antibody tests, I'm afraid. Well, not I'm afraid, it's a question, and it's a very valid question, that because we know that although the advice has been, and I've seen some questions come up on this as well in the chat there, in the Q&A, has generally been to people, don't just go out and spend your money willy-nilly on some test you can buy off the internet, because you don't know what that, don't necessarily know what that particular test means, etc. Will people get antibody tests after their 3rd dose, and would that be of any help? That's the first one we've got here.
So not at the moment. They're not being offered as routine in the NHS. The only people who get offered antibody tests as routine, unless it's a local decision, are those being admitted with infection, because it makes a difference about whether or not they get certain treatments, which I'm sure Richard will go into. I think in terms of the kidney population, we're quite used to monitoring vaccine responses sort of generally, both in dialysis and pre-transplant. If there comes a time when it will change management, for example, like I sort of mentioned about the prophylaxis, so if there is treatment that is going to be given to maybe people who don't respond to the vaccine as well, and you need an antibody test to dictate that, then I'm sure the NHS will make it more routinely available for everybody. But at the moment, an individual knowing their antibody status, apart from because they want to, which is a really powerful tool in my opinion, but they won't convince the people holding the purses, it's not going to change management overall. So it won't be available unless the management changes.
Right. Okay. So there's I don't know if you come across Virus Watch. So that's a study that the UCL are doing, and so we'll be sharing that in the notes after this webinar, because I believe they're looking, and that is it's just recruiting people to come and do. I think it's a finger prick test after your vaccine and send off those results. And whether that gives you how much personalized information or not that gives you, but it's one of those studies that's looking at what the antibody levels in the population. I think they're looking for people with kidney disease as well. So we'll be publishing something about that quite soon, which is just worth sharing to people, because that's something that we'll be sharing in the notes for this meeting.
Yeah,
Virus Watch, and there'll be other things as well, I suspect. Will there be?
Yeah, there'll be an announcement hopefully very soon when things get finalised about a large study, which obviously we'd like people to participate, to try and, because there's a big question about, do antibody tests correlate with vaccine efficacy, and that's a research question which would be particularly important in our population. So hoping there'll be an announcement about that quite soon.
So there's a new study that's just referred to, which is Virus Watch. There's other things as well, and that's all about seeing how well the vaccine works and whether that actually, what level of protection that actually gives you in real life. Right. Yeah. Okay. Thank you. Thank you, Michelle. That was an epic session. And can I perhaps go and get a quick drink if you want for a moment, and while we move back to Richard, if that's okay, Richard. Listening, so I don't know where Richard is, but I'm sure he's coming onto the screen shortly. While we can just, hello, there you are. Yeah. Where we can just talk a little bit about sort of options for protection for people. It's so in places where maybe the vaccines, we've talked a lot about the vaccines, about the antibodies and stuff, but we also know that some of these things don't work, and it's just perhaps we could have a little talk about that, because there's been loads of news about Ronapreve, which is one of the things that can be given. It's been approved, and about these new pills that may be made available to help people if they get COVID and so forth. So I wonder if you could just give us a little rundown on that, please.
Yeah, sure. So there's lots of different treatments out there, and I think what's becoming clear now that there are different treatments which are sort of aimed at different phases of the disease. So if you like, vaccines are at one end of the spectrum. So vaccines are given to people who don't have the disease, and it's just given simply to try and prevent people getting infected in the first place. So that's prophylaxis, as Michelle was just calling it. But as Michelle said, not everybody responds to a vaccine. There are then treatments included in prophylactic treatments are this class of drugs, sometimes called monoclonal antibodies, which are a type of treatment used across medicine in all sorts of different ways. And essentially all these ones is that some people have looked at the sort of antibodies that people who get infected with COVID produce. And typically they focus on the antibodies that these people produce against the bit of the virus called the spike protein, which you might have seen pictures of. That's the bit of the virus which pokes out the surface and what helps the virus infect cells. So scientists have looked at all the different antibodies that people produce against the spike protein, and they've tried to pick the best ones. And by the best ones, they mean the ones which can neutralize the virus the best, so stop it from infecting cells in the first place, and hopefully try and help kill the virus. So and there are thousands and thousands of different antibodies. We all produce different ones, but they've tried to pick the best ones, and then what they do is they try and engineer another cell in a laboratory to produce these antibodies over and over and over and over again. So they can be purified and given as a treatment. So monoclonal antibodies, as they're called, are just one antibody out of the thousands that we all might produce when we get infected, but which can be given to people. Now, they be given in different situations. They can be given as a prophylactic. So you can give people these antibodies who don't have COVID, they don't have the virus, but the antibodies will stick around for at least a few weeks, 4 weeks, maybe up to 8 weeks. And should you get infected during that time, they should reduce the risk of that infection becoming a problem for you. They don't reduce it to zero, but they should mop up. The idea is they mop up the virus early before it can establish a bad infection. And there's some evidence that some of these monoclonal antibodies work in that situation. You can also give them to people just after they get infected. So you take somebody who catches COVID, gets some symptoms, goes and gets their PCR test, and then as soon as the PCR test comes back, but before they become particularly unwell, you can give them these monoclonal antibodies at that point. And if you do that, what seems to be the case is that they can stop the disease progressing. They can reduce the chances of that person needing to go into hospital and help them get better more quickly. And then the final time in which you can use these monoclonal antibodies are when people have got COVID, had their positive PCR test, unfortunately have got more unwell, and then end up in hospital. And in that situation, we know that some people, when they present to hospital, will already have their own antibodies, but some people, as we've been discussing, for example, people on immunosuppression, might not have their own antibodies at that point. And if they don't have their own antibodies at that point, then you can give them these monoclonal antibodies and it will help them get better more quickly. And it will reduce their chances of them having a worse outcome from COVID. So these monoclonal antibodies can be used in all sorts of different people. At the moment, the NHS is using them in that final group. So it's using them, Ronapreve being the sort of the one which is, if you like, the leader in the pack, but there are many, many different ones sort of around and likely to become available in due course. But Ronapreve at the moment, but the NHS is recommending it gets used in people who end up in hospital who don't have their own antibodies. So they have an antibody test and it's found to be negative. And they recommend it if the person is either over 50 or if the patient is clinically extremely vulnerable. So, for example, transplant patients of whatever, or as long as they're 18 or older. So if you're 18 and you've got a transplant, or if you're over 50 and you don't, if you don't have your own antibodies when you turn up in hospital with COVID, then the NHS recommends that you get Ronapreve. At the moment, as far as I understand, NICE haven't decided whether it should be used in those other two scenarios that I described. Either people who are in the community who've just caught COVID, have a positive PCR test, but aren't unwell enough to go into hospital, or in people who haven't even got COVID to use them as a prophylactic. Although they probably do work in those situations, they haven't been recommended for use yet. And I think that is largely because these monoclonal antibody treatments are really quite expensive, and those groups of people are much larger than the groups of people who end up in hospital. So in terms of the health system being able to afford them, it's harder for it to afford it if you're going to end up giving it to more people. And particularly when you're thinking about the prophylaxis situation, where the people would have to have repeated doses, the costs there rise really quite substantially. And nobody likes talking about these sorts of things, but it does become a decision where the NHS and the government have to decide where they're going to put their money. Spending an awful lot of money to prevent a relatively small number of people getting more unwell, or do they spend slightly less money, but on people who are already unwell to try and stop them from having a bad outcome? So at the moment, the treatment is being delivered to people who are in hospital. Those monoclonal antibodies are being used for people in hospital. It's possible that in the future they will be used in earlier situations as well, but that's not currently the state in the NHS. There's also an issue with supply, in that these antibodies are quite difficult to make, and lots of countries want them, and it's difficult for the manufacturers to actually keep up with demand. So there's a relatively limited supply. But they're just one of the treatments that we've got. So as we've all heard on the news, there are other treatments which you might call antiviral treatments. So these are tablets that people take. Rather than a monoclonal antibody has to typically be given either into the vein or as an injection under the skin. But there are antiviral treatments like tablets. There are two which have made the headlines recently. One is a drug called molnupiravir, bit of a mouthful. I found out earlier today that it's called molnupiravir because molnu is the Nordic word for Thor's hammer. So they named it after Thor's hammer, thinking that it was in somehow.
Who knew that?
I didn't know that until but apparently that's it. So Thor's hammer to crush the virus. This drug was actually originally designed to treat flu, but they quickly tested it in COVID, and they found that it's, as you've seen in the headlines, does seem to be pretty effective for people who've caught COVID, have their positive PCR test, but are still in the community. They haven't been admitted to hospital. And these tablets seem to be able to reduce the risk of people getting worse and ending up in hospital. So there's that one. There's molnupiravir Pfizer, and we understand the government has bought about 500,000 treatment courses of that. And at the moment, it needs to make the decision of where's it going to use those 500,000 treatment courses. Because although 500,000 treatment courses sounds like quite a lot, as Andrew told us right at the start, there's still about 40,000 people a day catching COVID. So if you were to give everybody who caught COVID one of these tablets, you'd get through 500,000 treatment courses in about 2 weeks. So that's not a goer. So they've got to decide who gets it. And it's likely that vulnerable people, like people with kidney disease, kidney transplant patients, will be high up the list, but they need to make those decisions. There's molnupiravir, and there's another tablet, a bit like it, made by a different company, which doesn't actually have a name yet. And I can't, it's a series of letters and numbers, as far as I understand, made by a company called Pfizer. But again, that one's looking really promising at being able to prevent people who've caught the virus from getting worse and needing hospital treatment. And again, the government has bought or put an order in for an awful lot of that, and it needs to decide how to use it. Okay. So because the questions those treatments are all new since we spoke last time, and but there are more. But I think you want to ask me another question.
No, it was just really, well, obviously I'm aware of time as well, but actually that's fantastic. But those are the questions that people are asking very clear. You've answered, which to the extent we know it at the moment, which is, can we have these as a preventive, because we'd rather not get it if people who can't make who don't have the vaccine antibodies to provide a level of protection, it's access to that for that group of immunosuppressed people. And you'll understand why we've had, and there's loads of questions tonight about that as well, coming through. And so I think what you're saying is, because it's all so new, we're all excited about it, but certainly again, as Kidney Care UK, we want to know what, how those things are going to be made available, because the tablets look as though they might be a cheaper, less expensive option, I don't know, and could potentially be targeted at a group like those who are immune suppressed.
I suspect that is quite likely how they will be used. They'll probably be targeted at people who have what we call risk factors. So for some reason we think they're at higher risk than others, and that could be based on age, but it could also be based on things like whether they have kidney disease or kidney transplants, or indeed if testing is available, who don't have their own antibodies. That might be a way of deciding who needs extra help from the treatments.
Right, and just one quick point there. Anyone who goes into hospital with COVID has their antibody levels tested now, I understand. That's
the case since Ronapreve became available, because as Michelle was saying before, it wasn't done because nobody could have used it. We didn't really know what to do with the answer. But now that it drives a treatment decision, because if you don't have your own antibodies, then it might be that you're a candidate for Ronapreve. So the vast majority of people will be getting those tests done. Now, not all hospitals run these tests, my understanding, and some hospitals have to send them off to a local, bigger hospital to get the test done. So they don't always come back immediately. Doctors can request them, but it might be a few days before the result comes back.
Great.
It slightly depends on what's going on at your hospital.
Okay, but that's interesting for people to know that. So thank you, Richard. So we've got 3 more areas we're going to be talking about tonight. So if I could ask Andrew to come on very briefly. One's to do with boosters, then back to Richard about keeping yourself safe from work, which we've had a lot of questions about, and then finally around our emotional well-being. So we'll have to there's been so much discussion. I can see Becky has answered 40 or 50 questions live as well while we've been talking. So thank you as ever, Becky, for being fast on the keyboard. It was just really, and we've touched on this, so I guess it probably won't take too long, but as Michelle's already said, the chances are that there'll be a decision made about offering a booster dose to people who are certainly immune suppressed after their 3rd primary dose. What do you think, Andrew, about there being further booster doses in the future, just like we have, for example, flu jab every year? Any thoughts on that?
I'm sure that is describing the new normal, that we will now need to live with the fact that we're going to need booster doses against COVID-19 for the foreseeable future, until perhaps the virus mutates into something that's completely benign, like a cold, and has been suggested it will do this, but it won't do this in the near future. And if you are a kidney patient, you are likely to be offered boosters, and I would strongly advise that you take them up.
Thank you. And we've got one here. Is it safe to have repeated doses? Will there be a build-up of toxicity? And if I keep getting vaccinated, will I never build up any natural immunity? So there's 2 questions there.
So 2 questions. First of all, multiple vaccinations does you absolutely no harm. I think I've had now 10 flu jabs. I certainly don't get incremental toxicity. I just have my flu jab every year. And it will be the same for COVID-19. And it doesn't increase any toxicity of the vaccine. It just augments your immune response. And the only thing I disagree with Michelle is when she says it nudges your memory cells, I would say it actually kicks your memory cells into action. So it really is a bit more forceful. And the second question was, just remind me,
about the natural immunity, not building up any natural immunity.
Well, natural immunity is something you would get if you had been exposed to the virus and you got COVID-19, and it will reduce just like you do after a virus. So it doesn't, natural immunity, essentially vaccines are actually boosting your natural immunity, but they're doing it by another route, which is instead of getting an infection, you're actually being exposed to a part of the virus that stimulates an immune response. So there is nothing better about a natural immunity versus a vaccine immunity. It's not like we sometimes think about natural foods and all of this. It's not the same definition. So you still need your vaccines, you will need your boosters, and we will continue to need them, particularly if you are kidney patients.
And having vaccines will not prevent you building up your natural immunity?
No. Well, what will happen is if you did come into contact with COVID, you're much less likely to catch it. You're much less likely to have been to get seriously ill. But what you will do is, if you then are infected, that will give you another boost. It will be like having a mini booster.
Okay, thank you. Thanks very much. And do we know about how vaccine lasts in healthy people? I know we've had people asking whether so it's worth saying that household members can also, of people who are immune suppressed, are able to get a booster jab as well, even if they don't come into the over 50 or 18 to 49 with a health condition. So,
well, we know that antibody levels, and this comes back to what Michelle says, there's a big difference between what we know about antibody levels, but then there's a big unknown about what we know about actual protection. So we know that the antibody levels start to drop by about 6 months. And you do see people becoming infected, not necessarily, though, getting badly ill. So if you're living with someone who has been double vaccinated, they should get their booster, but they do not need to get their booster until 6 months, as is currently planned, 6 months after their last vaccination.
Okay, thank you very much.
That's nice and clear.
Yeah, no, very, very clear. And just a couple of things I thought I might mention here on this section. So the flu jab, it's now flu jab season. So if you get offered a flu jab, or ask for your flu jab, because if you have chronic kidney disease stage 5 or upwards, you would qualify both for a booster jab or a flu jab, and a flu jab, and you can have them at the same time or any combination of days apart. There's no rules on that at all. The other thing just to say is you can now walk in some places. You can actually walk into booster for your booster dose if you qualify for it in some parts of the country. And you can now book for your booster jab online when you reach 5 months. I believe that's the latest guidance. So if you get to 5 months after your last jab, you can go online and book it for 6 months' time. I believe those are some of the things that are coming in to encourage people. So that'll be for your family members as well. And someone has asked, will lessons be learned for the future on how to do better following the 3rd dose? And the answer to that is we certainly hope so. And we will do our best to push NHS England to do that. So I wonder if we could just get Richard to come on now just come back briefly for a session about work. So Richard, I don't know if you could bring your camera on, please.
I'm back.
Oh, there you are. Great. So we've had a range of questions that really about, how can I keep myself safe now? What do I do? Going to work, traveling, and how safe is it really for me to go out at all? So just a couple of things on that, if you would be able to.
Yeah, my patients in clinic ask me this a lot, and I find it a really hard question to answer. I think there is no such thing as completely safe, and there's no such thing as completely dangerous. Everything is somewhere on the spectrum in between there, and we all have a different level of risk that we would consider acceptable versus unacceptable. And I think it's really good that we've got one of your counsellors coming on later to help people, because this can just by itself raise anxiety. I think that's going to be really helpful. I think there are definite, and I think Michelle mentioned this earlier, there are other things to consider other than simply the risk of getting COVID or not. And for some people, being stuck at home for all this time has had a really bad impact on their mental health. And so to a certain extent, their physical health, if they're not sort of getting out and about as much as well. So I think those also need to be taken into account, which is partly what makes these discussions quite difficult, because everybody varies in what they think about acceptable risks, and everybody varies in the effects of staying at home has on their other aspects of their health, which is why there is no single right or wrong answer here. I would say that when people ask me that, I would ask them, how important is it to them to go out? What is it that they want to go out to do? Somebody asked me if they could go to their daughter's wedding. Was that a safe thing to do? And I said, well, it's no more or less safe than any other wedding you might go to, but it's your daughter's wedding, and I bet you want to be there. So you may want to take that risk, but take it with some extra precautions, rather than not take it at all. But yeah, it's very hard, and everybody's circumstances are going to be different. Just like everybody works in a different office, or everybody's place of work differs. So is it safe for me to go back to work? Well, that entirely depends on how your work's set up and what it is that you have to do there. So I'm sorry I'm not giving a black and white answer here, but I think there are lots of variables which everybody needs to sort of balance up for themselves in their own mind to decide what it is, and that will change day to day, as what the activity is that they're actually thinking about doing. So
I mean, would you agree that taking each activity on its own merits is the way to do it? But of course, to refer back to the things that we've said all along, if you can meet outside, for some people, obviously that's ridiculous in December in this country, in the UK, but sometimes, but in the daytime, meeting outside, regular lateral flow tests, continuing to wash our hands, wear masks, all those kind of things. I mean, a lot of people have said, talking about traveling on trains and how difficult that is, because not everybody, but trying to travel off of the main working rush hour, if at all possible. Would you agree with those things as things that employers, well, not just employers, it doesn't, not families, just people in general could? Yeah,
exactly. So if there is something you want to do, there's always ways in which you can do things you can do to reduce your risk. So if you're meeting up with people, can you meet them outside? Or if you can't meet them outside, can you make sure that the room is well ventilated? Is it possible that the people you're going to meet, that they can do lateral flow tests before you meet up, especially if that's a work thing? There'll probably be a regular schedule of those going on. So can you make sure that you're making the most of that? Wearing masks, you mustn't forget wearing that, they're really important. So I think there's all these things that you're quite right that you can do to, if you decide that you want to do something, you can then make steps to make it safer for you, just like you've described. Yeah. So
the message from the kidney doctors tonight is keep being cautious, but don't lock yourself away.
Yeah, I think so. I think you have to balance it with the potential benefits of whatever it is that you're thinking about doing, because there will be benefits to it.
Yeah. Okay. So just one quick question to you here about well, two actually, about, do we still need to wipe down surfaces or clean out, wash our shopping?
Yeah, so I think there was, others might disagree with me, but I think early on when COVID was around, when we didn't know much about the virus, there was concern that it could be transmitted from surfaces. And some people did some studies and found that virus could survive on the surface, say of your plastic bag from the supermarket for a day. And so people got very concerned and thought that washing hands and using gel regularly and things was really important. I think actually as the pandemic's gone on, we've realized more that actually airborne transmission is by far the most important for COVID. And probably wiping down shopping deliveries and things is probably much less important than people first thought.
So keeping windows open.
Yeah, it's all about ventilation, right? I think one of the reasons that people have stuck with the advice on washing hands and things is because that, as it happens, all has a lot of knock-on effects and benefits on other infections. So that's why people have been slightly reluctant to back away from it, because there's all those other bugs which are spread by surface transmission, which people aren't picking up at the moment because they're being very careful about COVID. Right. But actually for COVID itself, I'm not sure it's that important.
Okay, very interesting. Thank you. And there's a I think it's worth me just referring to the fact that on the Kidney Care UK website, we've got quite a lot of advice about people, going back to work, working from home, and things about going back to work and your rights to a risk assessment, and also the option again on the Kidney Care website of access to work, which is available for some people to get to work if you have a condition that doesn't depend on income. So some people listening might be interested in that, and you've still got your unions to support you as well. I know that there's been a push to kind of start to make things normal and stop working from home, but I feel as though there's still that balance there, and there's still quite a lot of people still working from home. So would you continue to say that working from home is a good thing for some people if they can do it? Because obviously, if you work in a supermarket, you can't work from home, clearly.
Yeah, so I think in a way we're lucky that working from home is much more of an option now than it was 10, 20 years ago. I think, yeah, it depends on the work that you do. It depends on what adjustments your employer can make and what your circumstances are like at work. If you work in an office, you have your own office at work, if you're one of those lucky people, then it's probably much safer for you to go back than if you're somebody who has to go back into a crowded office with very little ventilation. But you're quite right that any employer has to do a risk assessment, and you have a right to see that, and to request reasonable adjustments. It may be that what might be sensible is to if you are going to return to the office, do it, but not every day of the week. That you can come up with a balance between you and your employer, where you spend some time working from home and some time in the office, so you can get the benefit, and they can get the benefit of you being there in person for face-to-face meetings, but you don't have to take all the risk all the time, and you can still get a lot of work done at home.
Thank you, because some people will really, really want to go back to work and be frustrated if they can't go back. So I think it's really important to have that support and that balance as well. Lovely, thank you, Richard. So what we'll do now is, if that's possible, Sarah, if I could ask you to come onto the camera, and there you are, and perhaps there you are, that's better, I can see you now. You've been listening to all of that. What we're going to do now is we're going to just talk a little bit about some of the sort of anxiety and some of those thoughts that we started to get into there, and then we'll have a roundup of any further final questions before we finish tonight. So thank you for joining us this evening, Sarah. We're in the second year of the pandemic, and we've been living with this risk of COVID for a long, long time. We've heard from our doctors some great advice there, but any thoughts from you about how people can cope with the anxiety that they continue to feel about this situation?
So firstly, can I say that anxiety is a completely normal fact of life. Before COVID, we dealt with anxiety on a day-to-day basis. And so if you imagine anxiety on a scale of 0 to 100, where 0 is where you're really relaxed, you're lying on a beach, listening to the sea, very chilled out. 100 is where you're so anxious, you think you're going to have a heart attack and die. Before COVID, we probably bobbed around 20 to 30% mark, when we dealt with little stresses like being late to work or losing our car keys or things like that. So what COVID's done is it's pushed the base rate of anxiety up. And it's done this because we've had a world that nothing made sense, everything was out of control, and we listened to news broadcast after news broadcast telling us how out of control things were. And as humans, we don't like being out of control. And the other thing that COVID's done is, we had our very necessary and lockdowns. And what that did is it gave us the space to think about our anxiety and to really focus on, how anxious we all were. So what COVID's done is it's really created a perfect storm for anxiety. It's given us something to worry about and lots of time to think about it. So the question is, what can we do to reduce that base rate that's gone up so much higher? And there are various things that have been proven to reduce anxiety. Things like exercise, breathing techniques, socializing, talking to friends, spending time with loved ones, but it's different for everybody. So for me, for an example, running really helps me with my anxiety, as does listening to talking books. So for me, the running is really good because it helps me dissipate that really tense, worked up feeling that I get. And you don't have to be super fit to get that same thing. You can do that same tense energy can be dissipated by taking a walk, or you can get on YouTube and do a muscle relaxation exercise. There's lots of ways that you can get rid of that physical feeling. And with regards to the talking books, what they do for me is they distract me. They take me out of my going over and over and over what my worry is, and they take me out of my mind and put me into somebody else's world. So again, there are so many ways to find a distraction that works for you. That might be doing something like watching a film, building a model airplane, playing a computer game. So it's important to find what works for you. And also to find what things that not only work for you and help distract you, but have a calming effect. So for some people that could be knitting. So we're coming up to Christmas, what about knitting a Christmas jumper? Or it could be going through the family holiday photographs and making up a photograph album, or getting out there and planting up the bulbs for the springtime. It's about finding what helps you distract your mind, but also it's a really calming thing to do. So fundamentally, what I'm saying is, when we're feeling anxious, note that, and then take control of it and put something into your day that's going to just lower down that level. And in that taking control, actually that process in itself will help reduce anxiety. But lastly, the other thing is, it's really important to remember that the messages that we're giving ourselves. It's really important to just stop and recognize what we've already come through. You know, we are now in the second year of this full year of this pandemic, and you're still here. You've still got kidney disease, and the pandemic's still going on, and you've managed it. You're safe. You're still here. So just recognize how far you've come as well.
Thank you. Very wise words. And just, I suppose, just perhaps briefly a little bit on that same line about, if you're still, some people we've heard, some people will still be shielding and thinking about doing that over the winter. Is there any kind of, are there any thoughts about sort of making that risk reduction, but from the emotional point of view?
So it would be really foolish to deny that another winter of shielding is a really depressing prospect. And so I speak to kidney patients that are saying that this prospect's making them feel really low and a bit hopeless. And I think, and that it's a case of balancing your mental health with your physical health. And absolutely, people need to do what makes them feel comfortable. But if you're feeling low and hopeless, then clearly what you're doing and have done isn't working for you mentally. So I would encourage people to consider, what could you do differently this year that you can still do it, feel safe, but that will help boost your mental health. So we are in a different place, as we've heard from the doctors, this November than we were last November. Last November, where I live, we were in I think it's called a fire break, where we were all back in our homes for a while to help reduce the spread of the virus. This year, that's not the case. And last year we didn't have, we hadn't had the vaccines. So many of us hadn't had vaccines, and we didn't have lateral flow tests. We had so much less in our armor than we do this year. So if you know that seeing your grandchild, your girlfriend, your best friend, whoever it is going to really give you a boost, then it's worth considering get them to take a lateral flow test and come to see you. Because, that if your mental health improves, then you'll we'll get through this so much easier.
Right.
Sometimes when we're feeling low, our motivation to do things is just really, really low. And the less we do, the less we feel like doing, and we get into a bit of a downward spiral. And things to do about that are I speak to clients all the time that tell me I'm feeling really low, and I say, so what have you got in your diary to look forward to? And they tell me nothing. So everybody needs something to look forward to, and that doesn't have to be anything really massive. It can be having your mate round on Saturday to watch the football together. But so if we try to pepper our routine, our weekly routine, with things that actually they give us a little bit of a boost, that'll help us manage our mood. And putting a rhythm into your day, getting up at a certain time, going to bed at a certain time, and maybe even a rhythm into the week where, you know, Wednesday night you cook something new, or Sunday you speak to your mother or whoever on Zoom, or listen to your dad moan about the rugby. Just get a bit of routine into your week, so every day doesn't roll into the same as the last. You've got some things that you've done that are different and get you through the week.
So thank you. So we've got a question, you've seen this one about, is it normal to feel anxious in crowded situations? But in fact, I suppose that also comes up to a question that we've just had through the chat as well, because there is a risk at the moment. It's not, you know, it's not the risk that it's not the same risk, but there is a risk at the moment. So I think what you're saying is, you know, there's ways in which you can deal with it, but is it normal to feel anxious in those situations? And would you advise any techniques to do that, to deal with that?
So it's absolutely normal to, in a pandemic with an underlying health condition, to feel anxious in crowded situations. I talk to people who, without any underlying health conditions, that are becoming anxious on trains and things like that. So what can you do? Well, avoid them if possible. So if you have to go into work and you have to travel on rush hour, is it not possible that you can speak to your boss about coming in earlier or later and leaving earlier or later, so you're avoiding the real peak times? And obviously, you know, that's really great for the people that can do that, but there are going to be people that don't have that choice. And then in those occasions, if you don't have the choice, try not to have black and white thinking. Because you're in a train with loads of other people who potentially aren't wearing masks, it doesn't mean you're going to get COVID. It's not black and white. It's not one or the other. And try and take control of what you can control in the situation. So wear your mask. We were just hearing about gelling, but keep your hands clean, and you know, and sort of give yourself positive rather than negative messages. So don't tell yourself, I'm going to get COVID because I'm on a crowded train. Remind yourself that you're doing everything you can to keep yourself protected, and that you've come through this for the last 2 years, and there's every chance you're going to come through it until the end.
Okay. All right. Now, so I think it's worth reminding everybody that we've got, and we'll share some of the links. We've got blogs on mindfulness, things to think about, things to meditate on, etc., on our website. We'll be sharing all of those throughout, you know, as the meeting. In the report from this meeting.
So just quickly there, Fiona, on the mindfulness stuff. Very often, whenever people are using mindfulness, which I recommend all the time, they use it whenever they're feeling really, really, really anxious. And mindfulness is something that if you practice, so if on a daily basis, maybe as part of your routine that I was discussing earlier, you popped in that at 11 o'clock, you sit down with a cup of tea and you do 5 minutes mindfulness. When that will train your brain, you'll be doing brain training to help lower your levels. So when you're in that really anxious situation, it works better because your brain knows what it's supposed to do.
So practice it generally anyway. So Sarah, I'm going to have to call it to a close now. I think we've had about 10 or 15 minutes on it, but thank you so much, because I think there's a lot of things that people can think about in terms of what you've just said, different ways of thinking about all of this, because, you know, we have to acknowledge that the risk is real, but how you live with it is something that you can have some impact on, using some of those techniques and ideas as well. So I think what I'd like to do is thank you for now. We'll just have a look at any outstanding questions. Kelly, if we can just come back to everybody on the just perhaps to the I think there's a final slide that I wanted to have a look at, our second to final slide, beg your pardon. So this is the one that says about other resources. That's the one. If you could pop that up on the screen there, that would be fabulous. Thank you. That's the one. So I just wanted to remind people of some of the resources that we were just talking about, you know, just at the bottom there, you know, for financial advocacy and emotional support. That's what we do at Kidney Care UK. You can come through to that. Here's some of the tips there that will just build up on some of the things that Sarah was fantastically, brilliantly talking about, and about our own coronavirus set of information there. We've just gone through so much tonight. I wonder if we could just have all our speakers just on the screen, just so I can thank you all personally. If that's okay, Kelly, well, everybody actually, if you just pop yourself back on the screen again while we start to close down. I can see Richard. I don't know if the others are back on screen or it's just me. No, everybody's there. Thank you. So what I'd like to do, unless Becky or anyone tells me there's a question that we've absolutely got to answer now, I can see there's some fabulous stuff coming through on the Q&A actually as well. So we'll use all the different things that people are telling us here as well. What's this? So we did something called wild writing, write down for 5 minutes about the best thing that happened recently. I found this really recommended. Yeah, that sounds great. Thank you. We'll keep all those things. We'll keep all those things up there in the write-up for this, because I hope everybody agrees.
Yeah, now, could I just ask one thing?
Please, yes.
It came through in a lot of questions, is that people who had got their third dose as a booster, so they were offered the booster and they took it, but also had been eligible for a third dose. And I suppose one of the things I wanted to talk about was if it was a Moderna, there's a dose difference between the booster and the third dose, and to send people to your website where there's a really clear flow sheet for patients around how to navigate through all this third dose and booster. And I think if the team will put a reference to that, but I don't know if anyone else had any advice, because I think there's some concern that if they got the third dose as a booster, would they then still be able to get their booster 6 months subsequently? So I just wanted to say that because it came through on a lot of questions.
Thank you, because I didn't see half the questions coming through there. I know we've got to close down, but I think that's a very reasonable point, and that's something that we will keep pushing NHS England on as well. But if you've had your third dose, then, well, other people should say, actually, any of the doctors rather than me. Anyone else want to add anything to that?
So all in the vaccine database, all third doses went into the same box with regardless of whether or not it was third doses or booster. So I just think it'll be very important in 6 months' time or 6 months after third dose that these patients are appropriately identified. And I think there will need to be a bit of work done to ensure it's going to be smoother in 6 months' time than it was just gone. Yeah.
Okay. No, that's fine. And I think we've been given a lot of assurances on that. So we will all be working. We're very, very focused on the fact that that is a potential issue, and we want to work. And we'll be working with all of our medical colleagues on that as well. And as soon as we've finished with the third vaccine, which hopefully will be quite soon, that's one of the next campaigns. So everyone should be reassured that we are very painfully aware of that as a possibility. So I wonder, Kelly, if you could I'd like to thank all of our speakers for their time, their contribution. It's very intense running a webinar, taking part in a webinar like this and being kind of put on the screen. So thank you everybody for all of your help, for all of your support, for your engagement on this. Kelly, could you put the final slide up there, please? And if anyone would like to support any of our work, any of the advocacy or counselling or grants work that we give, that would be fine. And what that will be in, I think we put something in the chat there, how to support us. Oh, we just put something else in the chat here, which is that link to the document that Kelly just, Becky just mentioned, which is a nice flow sheet for people to have a look at about what should happen first, third jab and boosters. But just to say, we're going to there'll be a little survey to do after this, which we'll send you. Do please let us know what you think of this, if we're doing the right thing, if we need to do more, and also if you would like to support us or sign up to us for any of our future work, that would be fantastic. And thank you so much for all of your time tonight, and take a look at the chat. There's another little link there to supporting our work. So I think that's it for now. I think we should say good night, everybody, and thank you very much indeed for staying with us. And thanks to all our speakers. Have a good rest of the evening. Bye-bye for now. Bye. Bye, everybody.